Medical Center. I'm happy to be here today. Okay, so if you were present in our last class, we talked a little bit about gastroenteritis. Feel free to ask any questions if you had any about the contents of the previous session, okay? We talked about the case with gastroenteritis. We emphasized on the importance of compensating for the fluid that the patient has lost, for the maintenance, for deficit, and for ongoing loss. We learned how to calculate maintenance. First 10 kilograms, 100 cc per kilograms. Second 10 kilograms, 50 cc per kilogram, and third 10 kilogram and more, 20 cc per kilogram, okay? And then we talked about the dehydration, the percent of deficit in each person. And we learned how to calculate that regarding the signs and symptoms of a patient. Okay, so we multiply patient's weight by 10 by the deficit percent, and then that's the deficit for 24 hours. And we should calculate the sum of deficit and maintenance for calculating the total amount of fluid that the patient needs in 1 day, okay? We also talked about stat serum therapy. It means that in the first few minutes, in the first 20, 30 minutes, 1 hour of serum therapy, we need to maintain a bolus of fluid, a total amount of fluid for restoring the perfusion of the child. So we infuse 20 cc per kilograms of normal saline, and then after that, we will administer the rest of the fluid that we calculated. So if we calculate the maintenance and the deficit fluid of a patient, the maintenance and the fluid that the patient needs, and if we administer these stats in the first 30 minutes, we should subtract the stat from the total maintenance and deficit to have to calculate the rest of the fluid that we need to administer in the rest of the day. Then we talked about ongoing loss. No, we didn't talk about ongoing loss, right? We talked up until ongoing loss. So if you have any questions up to here, please ask me, and then we can continue the class. Are there any questions? Is everything clear for you? Are you familiar with how to calculate maintenance and deficit? And you're able to see the screen, right? I'd be glad if you could show some vital signs of your results. Okay, thank you, dear Fatima and Mubashir Ahmed. Thank you. And Ranga, of course, thank you. Okay, so we're going to talk about ongoing loss, okay? The serum, the fluid that you maintain for any patient, for a child or for an adult, includes 3 parts, as I previously talked about. Maintenance, deficit, and ongoing loss, okay? Let's assume that the patient is referred to you today with diarrhea, okay? You see the patient and you calculate the dehydration as moderate, okay? So there is one. Irene has sent something. I cannot see the smiley here, okay? So you see that patient, you understand that the patient has moderate dehydration. Then you calculate the amount of fluid that she needs as maintenance and as deficits. For example, she is 4 years old and she is moderately dehydrated. So you multiply her weight by 6, that is the percent of deficit in moderate dehydration, by 10, that is the constant number, okay? Now you have the deficit fluid that you have to compensate over the last 24 hours. But the patient has diarrhea, okay? Maybe she goes she defecates, she has diarrhea for 2 times a day, maybe she has defecation 10 times a day, maybe 20 times a day, okay? In this point of time, you do not know how many times she's going to defecate, okay? You're just calculating the amount of fluid that you're going to administer over the next 24 hours based on your interpretation of the dehydration of the patient now, okay? So, what we say is that you should administer some fluid equal to the amount of a stool that the patient passes each time, okay? For each time of defecation, we will tell the mother of the patient that for each time that the patient has diarrhea, each time that she passes a stool, you should give your child this amount of fluid so that you compensate for that amount of stool that is passed, okay? So that is what we are going to do. And since the contents of the stool are some special electrolytes, besides water, like sodium, potassium, and chloride, and of course, dextrose, glucose, you're going to compensate by giving the child these electrolytes, okay? We have a product called ORS, oral rehydration salts, okay? It might be flavored like this trademark here that is flavored orange so that the patient takes it better and it tastes better, okay? So what you should ask the mother to do is to add this powder, this amount of powder, this whole pack, to 1 liter of water, okay? And then restore that in a jar or in a bottle and keep that in the refrigerator, okay? Each time that the patient defecates, the mother should give the patient 10 cc per kilograms of that fluid, of that suspension. It's very important that you understand this and that you emphasize the mother to do that exactly. It's not okay that the mother just adds some amount of this powder to some amount of fluid, you know? It should be followed exactly like this. The total amount of this pack dissolved into 1 liter of fluid. Then for each time that the patient defecates, the mother will give 10 cc per kilograms of that fluid, of that suspension, you know, of that solution to the child, okay? So did you understand the concept of ORS therapy? Okay, so now this is what we do now because ORS is widely available in nearly all of the countries and all the regions. But this is the traditional way to make ORS, okay, the solution of ORS. You can do this easily at home. You can add 6 levels of sugar, 6 level teaspoons, excuse me, of sugar, and a half level teaspoon of salt to 1 liter of water, okay? The suspension, the solution that you will have is just like the solution that I described before, okay? Because that's what ORS contains, salt and glucose and water, okay? The ORS solution. But try not to suggest that to mothers because ORS is not expensive and it's widely available, and it's better to follow the rules that are written on the pack of ORS powder, okay? So that's what you will do. And well, sometimes we cannot ask the patient to drink the ORS fluid. Maybe the patient is vomiting, okay? Maybe the patient is severely dehydrated and she's not able to drink anything, okay? So for the patients who are hospitalized and who are in this condition, we can prescribe the ORS in form of serum therapy. The exact contents of ORS can be packed into a serum package, okay? And then the nurse will prepare this solution, will connect it to the patient, and for each time of defecation, of passing stool as diarrhea, The mother will come to the nurse and tell her that the patient has defecated. So the nurse will administer 10 cc per kilograms of this solution. It's just equal to the jar that I described to you before, this jar of ORS solution that I told you before. Okay? So there is no difference. You can do this in the hospital. Okay? And I don't know if I told you this before, what patients we should admit. If I have, I will emphasize on it again. There are certain patients that we try to admit in cases of diarrhea, okay? You always admit the patients with severe dehydration. It means that you should admit him and you should start serum therapy or IV therapy, okay? The patients who are unable to take PO, to drink fluid, to eat, these patients should also be admitted. And the patients who have heavy diarrhea, as much as it cannot be kept in the diaper, okay? When the patient has so much diarrhea, has such a heavy diarrhea, the mother is not usually able to compensate for the fluid that the patient is losing, okay? Because the poor mother has to change the diaper, has to clean up the baby, has to do these chores, and then she should go search for the ORS and give ORS to the patient. And because this is so hard and the patient is usually having the diarrhea so frequently, we tend to admit these patients because we need to administer the serum therapy ourselves, okay? Moderate dehydration, I wrote it here, but it's not an absolute indication for admission of patients, okay? But here, because we can and we have the facilities, we usually tend to admit these patients, okay? Because we usually assume that the patients who are moderately dehydrated now will soon become severely dehydrated because the mother was not probably able to compensate for a mild dehydration, and now the mild dehydration has changed into a moderate dehydration, okay? So moderate dehydration will soon become severe and the mother will not still be able to compensate for it. So we tend to admit the patient, okay? So I emphasize on the indications for admission. And so as you see, when we have a patient with severe dehydration or when the patient is unable to take PO, then we can admit the patient. And when we have admitted the patient, we can either give the patient ORS in form of therapy if the patient is able to take it via PO, via oral therapy, or we can administer serum therapy. No, for exam purposes, you admit the severe cases, severely dehydrated patients. Okay, so what your book says about the patients who are not admitted, okay, and who are going to stay at home, they're either mildly dehydrated or moderately dehydrated, okay? Your book suggests that, first of all, it means that you're visiting a patient who has diarrhea and who has mild dehydration or moderate dehydration. You should ask the mother to give a bolus of 50 cc per kilograms of ORS to the child. Okay, for example, the child is 10 kilograms, okay? You will ask the mother to give 500 cc's of ORS over 4 hours. Okay, make sure never to ask the mother to give a lot of ORS fluid to the patient at once because it does not taste good and the patient is vulnerable to vomiting because of his condition, gastroenteritis, and she will vomit, okay? So ask the mother to give it spoon by spoon, little by little, sip by sip, okay? So you will ask the mother to compensate for 500 cc's of ORS over the next 4 hours for a patient with mild dehydration. And for a patient with moderate dehydration, the amount is equal to 100 cc's per kilogram. It means, for example, for a patient with 10 kilograms, 1 liter of ORS should be prescribed over the last 4 hours. At home, this patient is not admitted, okay? So at home, we will ask the mother to do this, or for moderately dehydrated patients, what we usually do is that we keep the patient under observe, and then we ask the mother to give the ORS while we are watching, while we are around, okay? Because we want to see, we want to be sure that the patient's dehydration is being restored, is being compensated, and then when we make sure that, well, the patient is taking the PO and is becoming better and the condition is becoming better, then we ask the mother to live with the child and to continue giving the child 10 cc's per kilograms of ORS for each stool, for each time of defecation. Okay, that's the whole concept of ongoing loss. Are we okay with it? Did you understand well? Okay, wait. Another yes, and we will continue. Is everybody, okay. Irene, Ivana. Okay, so, okay, thank you, Farah. Another important thing that you should keep in mind is that the patient who is being kept in the hospital and you're doing IV therapy for this child should be monitored routinely, okay? All these tables are dragged from your Nelson Essential book, okay? So your book says that monitoring therapy should include these. Checking the vital signs, well, it's very important. You should check routinely for pulse and for blood pressure. The first time that you're visiting a patient with diarrhea, it's very important to check the pulse and blood pressure too, because it's important to understand if the patient is in shock or is not. And also, these vital signs will help you determine the severity of dehydration. If the patient's blood pressure is low, if she's too much tachycardic, then she has severe diarrhea. Okay? There's a black box on your screen. Is it still here? Oh, I think it's the chat box. Wait. Is it okay now? Okay. Thank you. Okay, I think it's fixed now. So the first time that you visit a patient, it's important to take the vital signs, and then you should routinely check for the vital signs. You should calculate the intake and output of the patient because you should be sure that the fluid balance is okay. It's important not to compensate the dehydration of a child, you know? Does anybody know what happens if we give too much fluid to a patient? What are the dangers of giving too much fluid to the patient? Yes, cerebral edema, brain edema, right? Ascites, yeah, can be right, okay. Another important thing. Hyponatremia, great, yeah, if you give, especially if you give hypotonic fluid to the patient. A very important complication, a very important adverse effect is heart failure, okay? The children are prone to pulmonary edema and heart failure, okay? All the patients are prone to that, even adults, but the children are very much in danger of pulmonary edema, okay? So when you administer lots of fluid to a patient, the extra fluid will go into the third spaces, okay? One of the complications can be ascites, but it's usually late and it usually happens in patients who already have problems like nephrotic syndrome, okay? What is more probable that the patient progresses pulmonary edema. Okay, and do you know how you can understand that the patient is going to have or is in danger of pulmonary edema now? What are the signs that you can find in a patient who is now having pulmonary edema or heart failure? Yeah, shortness of breath, dyspnea, yes. Chest pain, yeah, might be. Two important signs that usually progress rapidly. Crackle, that's very important. Thank you, Magan. PND, what PND? Which PND? We have orthopnea. Yeah, orthopnea. That's right. Yeah. Yeah. But there are two signs that you as physicians can easily find on a patient, that is being administered fluid therapy. You should auscultate the lungs of the child to search for crackles, and you should also palpate the abdomen to search for an enlarged liver. These are two signs of heart failure that progress rapidly after pulmonary edema and after administering lots of fluid, okay? So it's very much recommended and it's asked that you palpate the abdomen and auscultate the lungs before administering any fluid, okay? When you want to administer the bolus of fluid, first of all, auscultate and palpate, okay? Administer the fluid, and after each time that you give the bolus of fluid, because that's a lot of fluid, 20 cc per kilogram is a lot of fluid for a child to be administered in 30 minutes, okay? You should check for the liver enlargement and crackles of the lungs, okay? That's very important, and it easily happens. Don't think that it's a rare sign and it never happens and it's a very rare complication. It's a very common complication, okay? It happens more than you think, okay? So after each time that you give a bolus of fluid, you should check for these. And also during a day when you're giving a deficit and maintenance therapy, when you're giving any kind of IV therapy to a child, try to do this once at least or twice a day, okay? Check for the liver enlargement and the crackle of the lungs. And also tachypnea is very important that you all mentioned. It's very important. But many times the patient is already tachypnic, because of baby dehydration, maybe other problems, lung problems, okay? You may not easily recognize this, but if that happens, for example, liver enlargement, because you have already palpated and you're sure that there was no liver enlargement before giving the bolus of butter, the fluid, and now the liver is enlarged, so absolutely you have made something wrong here, okay? But if the patient has already an enlarged liver, okay, there might be other diagnosis rather than heart failure. For example, he might have problems with liver itself, okay, or metabolic problems or other things, okay? Not only heart failure, but first you should make sure that there is no problem with the heart, and then you can give abundant amount of fluids, as much as you want, okay? And in the physical exam, you should make sure to calculate the weight. Usually for children, we do not do this routinely every day, but for example, neonates, it's very important to check their weight each day, because their differences in their weight is easily recognizable, okay? But when a child is admitted, for example, 10 days in a hospital, then you should make sure to check their weight. It's important if the child has lost weight or has gained weight. If she has gained weight, it's probable that you have given him lots of fluid. If she has lost weight, it means that she has not been fed well during this admission, okay? And the clinical signs of fluid volume depletion or overload are important. I explained about overload, there are other signs too for overload. For example, edema. It happens a lot. The mother tells us, or we ourselves understand in our visits, that the patient has edema in his eyelid area, okay? And then we just decrease the amount of serum, and then we see that it's okay now. So it's you know, an iatrogenic problem, an iatrogenic mistake, okay? That we give lots of fluid, and then the patient becomes edematous easily, okay? And you should make sure to check for electrolytes for a patient who is being administered IV therapy once each day, you know. So because you're giving this patient sodium and potassium via IV therapy, and maybe she's being fed besides this IV therapy, you should make sure that you have not made the condition worse. You have not made mistakes in the electrolyte administration, okay? So, there was something that you asked me in the last session. You asked for the serum type. You asked what type of serum we are giving the patient. Okay, it's not very important for children, no, for students in the stagiary to know the types of serum. But I wanted you to be familiar with the concept, so I will explain a little bit. For all the patients, adults or children, the stat serum, the stat means the serum that you administer in a short time, in, for example, 30 minutes, okay? It should be in form of either normal saline or ringer lactate, okay? Normal saline does not include any potassium, okay? So you administer this fluid only because you want to give the patient a bolus. You want to reperfuse the child, okay? So it has no electrolytes, and it's always the normal saline. But after the bolus therapy, the serum that you give to a child, not an adult, to a child, always includes dextrose, okay? It should have dextrose, it should have glucose. A child cannot be kept on a diet without glucose, okay? Unless the patient has some extreme conditions like diabetes, ketoacidosis, that's different, okay? For normal children, we always administer a serum with dextrose plus sodium, potassium, and chloride. Look here at the example. For example, we write this in our orders. Serum, dextrose, water, 5%, 1,000 cc's, plus 50 cc's of sodium chloride, 20%, plus 10 cc's of potassium chloride, 15%. This is how we write it in our orders, okay? And the calculating is a little difficult, and it's not really needed for you. So let's not get into that. If you're okay with this part, we can continue. Did you understand?
क्या वहाँ कोई बात ही नहीं कर रहा है? 10 बच्चे हम टोटल है.
Okay, great. I like the accent of the person that talked. You can talk to us too. We will be glad to hear your voice. Okay, so enough with the serum therapy. I will emphasize again that the most important thing that you should do for a patient with diarrhea is to restore the fluid and the electrolytes, okay? So assume that you're sitting in a clinic or sitting in the emergency ward and a patient comes to you with diarrhea. It's not important whether this diarrhea has an infectious source or it's because of some drugs or because of inflammatory bowel disease. You should just, first of all, restore the fluid. And that's what you all know how to do up to now, okay? But after this step, after you have made sure that the patient is not dehydrated and is well hydrated and knows how to go and the mother, in fact, knows how to go home and administer the ORS for the child. Now, you as a doctor should find out what the source of this gastroenteritis is, okay? As I told you, there are different differential diagnoses for gastroenteritis, like taking some drugs like laxatives, like some antibiotics, okay? and also inflammatory bowel disease. Inflammatory bowel disease, like, as we call it, IBD, like ulcerative colitis or like Crohn's disease, are diseases that involve the layers of the intestine, and there's inflammation in the intestine, so the patient has routine diarrhea and with abdominal pains. Maybe the diarrhea is bloody, and the patient might have other problems too, like rheumatologic manifestations, like skin manifestations, okay? But that's not acute, that's a chronic problem. So there are some signs in favor of an infectious source for gastroenteritis, like fever, like vomiting, like an acute episode with no chronic, with no chronicity, Other viral symptoms. For example, a patient comes to you with coryza, symptoms of coryza, rhinuria, sneezing, conjunctivitis, okay? And she also has diarrhea. So it's very probable that this diarrhea has a viral source, okay? Positive case index, there are 3 children in the family with diarrhea. It's very, very probable that it's infectious. Maybe they have all eaten a bad food, The bad food is usually infected with some pathogens, like staphylococcus, for example, okay? Like E. coli. And the recent history of travel. These are all suggestive of infectious gastroenteritis. So what we should do if we're in doubt of an infectious gastroenteritis? Do all the patients need to go through a stool exam? Should you ask all the patients to go and give a sample of a stool exam? No, that's not what you do. Yeah, thank you, Amaka. Only in these cases should you ask for the stool exam. A stool exam is always, in fact, checked with the stool culture. You will ask for the stool exam, which gives you RBCs, the number of RBCs and white BCs in the stool, and also stool culture. Stool culture will be ready after 3 days, okay? But the stool exam will be ready after 2 hours. You can interpret the stool exam easily and decide if you're going to give antibiotics to this patient or not. Only in these cases should you ask for a stool exam if the patient has bloody diarrhea or if the patient is ill, appears ill. We usually admit the ill patients, okay? But you do not need to admit the patients with bloody diarrhea. The indications for admission are those that I told you: the severe dehydration, the heavy diarrhea, sometimes moderate dehydration, and inability to take fluids via eating, PO, And it's very important that you do not prescribe antibiotics without checking a stool exam. I will tell you why. So now we're okay. We know when to check a stool exam, okay? Only bloody diarrhea and ill patients. So we have the result of a stool exam now. What should we do and how should we interpret it? If the stool exam is normal, it means that there is no white BC or RBC in the stool exam, then it is most probable that the source of the gastroenteritis is viral, okay? And viral gastroenteritis does not to be treated by antibiotics. It will just need some time, okay? But you should ask the mother to keep the patient hydrated, as I told you. But there is no need for antibiotic administration. But if you have white BCs and RBCs in your stool exam, if there are more white BCs than RBCs in the results of a stool exam, then that's in favor of bacterial sources like Shigella and Salmonella. And in this case, this diarrhea should be treated. Yeah, Irene, I will explain about that. Okay, I will explain. How white BC in a stool exam is normal. Usually up to 5 RBCs or white BCs can be assumed as normal. But if you have a clinical doubt, if you, for example, your patient is very ill, there is no, I will explain about it later, okay? I will explain about it about the clinical judgment later, but just know that up to 5 white BCs or RBCs are usually normal unless you are in clinical doubt that this patient's diarrhea has a bacterial source, okay? I will tell about this clinical judgment later, okay? If you have more RBCs than white BCs in your stool exam, that is in favor of enterohemorrhagic E. coli. Enterohemorrhagic E. coli, if treated with antibiotics, will lead to hemolytic uremic syndrome, which is a very bad syndrome. Do you know what happens in hemolytic uremic syndrome? Does anybody know that? Can lead to kidney failure, right? HUS, yeah, that's hemolytic uremic syndrome. Yeah, that can lead to kidney failure. It's a condition of hemolysis. You will see schistocytes in the blood analysis, in the peripheral blood analysis, and the patient's creatinine will rise rapidly, and it can lead to kidney failure. Even it can lead to neurologic manifestations, and maybe the patient will need dialysis in a short interval, you know, seizure, right? Hemolysis, yeah, right? So it's important that you avoid giving antibiotic to any patient with diarrhea. That's something very routine and it's very bad. If a patient has diarrhea, only ask for a stool exam if it's bloody or if the patient is ill, okay? If you check the stool exam and then you see white BCs more than RBCs, then that's the time that you prescribe antibiotics. Otherwise, you're not going to prescribe antibiotic, okay? And especially avoid antibiotics if there are more RBCs than white BCs, okay? So about the question that you asked about the parasitic infections, yes, parasitic infections can cause abnormalities in stool exams. And that's why we usually we always check for stool culture, because based on white BC and RBC, we cannot judge the culture, the pathogen easily. Okay, so when the culture is ready and the patient's results show us, for example, sometimes amibs can cause diarrhea. Okay. If it's amib, then you will just treat it according to the found pathogen. For example, metronidazole can be administered, okay? It's not very common unless you are in endemic areas, okay? So if you're not in endemic areas, try to have a base, have an expectation that the usual sources are Shigella and Salmonella, and those are the sources that need to be treated, okay? Other sources do not to be treated. But if you're in endemic areas, well, that's different, okay? And amib should be treated, you know, a little extremely, you know, with iodoquinol after metronidazole administration, and it has its own protocols, okay? And but usually other pathogens, like for example Giardia, these kinds of pathogens, if you're in doubt of them, you should ask for OP. No, it means parasites in the stool. Then they will check for, they will use some special laboratory techniques to detect the parasites and the specific pathogens. And well, the symptoms are different. Usually, for example, the patient who has Giardia, the symptom is not acute gastroenteritis. He has gastroenteritis, bloating, the stool that is usually sticky, you know. He has distension of the stomach. He has malabsorption. The signs are a little different. It's not only fever and diarrhea, watery diarrhea. Okay. And about another question that you asked. I was talking about clinical judgment. You know, Shigella is a very important pathogen because it can, if not treated, it can have some catastrophic outcomes. Okay, and Shigella can have some specific presentations. For example, neurologic symptoms are usually, not usually, but are sometimes seen in Shigella cases. Okay, and also the patient might not have control on the stool passage. It means she has incontinency. Okay. Fecal incontinency, that this happens in Shigella cases, and the stool has a very bad odor, has a very bad smell. Okay, so if your clinical judgment is consistent with Shigella and you see that this patient really has these signs and you're very much in doubt of Shigella, then you check the stool exam and you see, for example, that there are only 5 white BCs and no RBCs. Okay, then you should assume that that's Shigella. Okay, and you should treat it. You always trust your clinical judgments more than laboratory evaluations. Okay, you're welcome. Okay, so and these are the drugs that you prescribe for the child who has Shigella or Salmonella, and who in stool exam has more white BCs than RBCs. Okay, the best drug to use in children is Cefixime for children who are not admitted. Okay, the Cefixime has syrup and has tablets. In your in fact guidelines of diarrhea, of infectious diarrhea, ciprofloxacin or fluoroquinolones are suggested as the choice therapy, but usually we do not prescribe them in children as the first therapy because we do not want the child to be resistant later in life to ciprofloxacin. We want to reserve it for more serious diseases. Okay, azithromycin is another choice in these patients, but the best one and the most routine one is Cefixime. And in cases of admission, ceftriaxone or cefotaxime, these are all third-generation cephalosporins, and also ciprofloxacin and azithromycin. And the duration of therapy is always 5 days. Okay. So at the end, I insist again that the most important thing to do is to restore the dehydration. Please take dehydration very seriously. And then after that, you can think about the etiology and the management of diarrhea. So I will be glad to hear your questions and answer them now. What should be the osmolality of the ORS fluids? Are you asking this for your exams, or you think it's important in clinic? Because the osmolality of ORS, I think it's around 250 to 300. Okay. Yeah, that's it. Yeah, 250 to 300, as I remember. Okay. But it's not important when you want to make it, because you always should follow these rules of dissolving 1 pack of ORS into 1 liter of fluid, and that's of water, and that's the solution that you want. But in exams, that's it, 250 to 300. It's a little hypoosmolar. Previously, we tried to keep it isoosmolar, like the osmolality of blood and of the stool, but now they recommend that it should be a little hypoosmolar. Any other question? Is diarrhea a symptom of COVID in children? Yes, of course, it's a symptom. It's a very routine symptom, of course, now, and it's important that you always ask the child with diarrhea nowadays if she had a contact with a person who had COVID, if she has other symptoms and signs like sore throat, if she's able to express that, like coughs, like respiratory distress, you should check for that. And now we routinely, for the patients who we admit in the OR, in the emergency ward, ED, for COVID PCRs. Because there are too many cases of COVID now and of GEs, we usually check the CBC, and then if we are in doubt of COVID, then we check the PCR. And you know, lymphopenia, for example, is in favor of COVID-19. If we see that the patient has lymphopenia, or he has a high CRP, or there are positive case indexes, or there are other symptoms of COVID, then we check for COVID PCR. And there is no specific treatment for it. So it's just for knowing that the patient has COVID. Another important thing, you know, is the concept of MISC. I don't want to just mix it up for you, but it's a result, in fact, a catastrophic result of COVID-19 in children. It involves multiple organs in children, okay? The child with COVID-19 might have involvement of both respiratory system and gastrointestinal system, or for example, neurologic system or blood system, or in fact, involvement of joints, for example. If there are two systems involved, for example, both respiratory system and gastrointestinal system, that might be a sign of MISC. And then you should check for some other laboratory evaluation and should do the echocardiography just to make sure that the patient does not have MISC, because MISC has catastrophic results and it has a very good treatment. It has the treatment of methylprednisolone pulse and also IVIG. So it can be easily treated, and if not treated, it will lead to death. So that's what we usually do because we can easily, you know, we can prevent that to happen. But in cases of pure COVID, well, we cannot do anything unless the patient is very ill or has this respiratory distress, so that we administer remdesivir, dexamethasone, or things like that. Any other questions? Okay, I hope that you have learned well how to calculate the serum and the concept of fluid therapy and antibiotic therapy. You're welcome. If there are not any other questions, I think you're welcome. I think that's enough for today. You're welcome, dear. You're welcome. Have a good day. And goodbye, guys.